You know, being a,
Tell you what,
do you guys do buying and then renting a vehicle, or do you?
Yeah.
Your own
Taking my
vehicle?
time.
Well, it
I'm
depends
actually-
on how far, so I have my own vehicle.
That's refreshing.
That would send you if it was close enough.
On the
But
OPAs and the
It's a, if it's a
NPAs,
national
all the basic
contract, it's
stuff we already
You can go anywhere.
so, if it's
I never think
feasible
about, like,
for you to
oxygen
go
being a base
and rent a
of-
vehicle or to
Yeah,
drive, then we
that's
will
what
send
I
you in a
thought.
vehicle that's already like ready to
They're
go.
kinda hammered on that.
If
So
not,
those
we
are
fly
good
you.
ones. I did the CPAP, lower blood pressure.
Cause I'm not 25, so I don't know.
With what hypertension.
Oh,
Having a little problem breathing, you
that
want-
hasn't been a problem in the past because I rent
That's
them
what I was asking.
and put you as a driver on there.
It's not protocol, so.
Well, there, if it says on the book. that
God, now I gotta think about that.
genetics
I
in
don't remember
some
what I did.
locales, They take IV drugs that are for hypertension,
Yeah, but I have.
beta blockers even, like
But yeah,
hypertension.
no, I would be.
Can't do any of that.
good for that.
Yeah.
I don't know when, I mean.
Well, send me your certs. I
just
can,
kinda, yeah.
I can throw you on the roster and you're there.
Yeah,
go out.
Whoever calls me first. Well, that's the same thing I told Evergreen now. Do you wanna go on assignments? I was like, "Hey, let me go.
Tells me first, exactly, 100%. That's what this world is, right?
Yeah.
Oh, cause what is it possible to do with her? Or even, or just Steve you can, I
Yeah,
guess.
is it? Then I gotta do dishes.
I'm opening it.
Yeah.
I can barely keep up with that.
Oh, tell Kyle what you told me about watching the
That's a
Zoom.
lot,
Oh, I went to pull up, last week's,
Well, don't feel bad.
Zoom class.
It's like.
and I was able to pull it up, and then I had to put in.
No, I forget it.
Password.
I thought you,
Something
because I was
to
wanting to
actually
stick
watch
with
it.
it. and
I had no
I'm
idea
gonna
what
stick
it
with
was.
it. But I will. You hadn't even done the assessments, finished all the assessments.
Us either?
Do the assessments, do the first 5 quizzes and do that exam, because they're not gonna release the answers for the exam until everybody's taken it. So,
All right, well, let's try to figure that out after class. Might just be. Zoom.
Tried that number.
Like a social security, no, it's not. I was gonna say, infinite money hack.
You have to make me a co-host so I can let people in.
This number.
That's the same one.
very cheap to get back in that or something, you know, just say, see what your flow is like, you know, when you're breathing in.
We might have to ask him. I don't know. No one else has told us.
We don't have any humidifier.
You know what else?
Bill?
In our ambulance.
No, we don't do big long IFTs. We just
Okay.
have.
At Polson, we do have people that go on fires, but, usually they're not our, but 911, not full time.
No.
No humidifier.
Humidifier, oh yeah, we have humidifiers. I thought you said
Okay.
fires. No, we do.
Said in the
We
book.
do have humidified
We,
oxygen.
we've never had, well, we have, seeing, said in the book that requires like special precautions and stuff for bacteria and everything.
Oh, for sure. I think,
Yeah.
yeah, because it can, promote growth, but I
Right.
think
I don't know, we did all those transports, I never saw one.
I mean, I've not used it, and I think very rarely I've seen people actually use it, but we do have the equipment to do it.
Is it a separate tank? Or does it have a?
I think it would.
Little, I've run, well, I've run humidified, it's like a little cup deal that mounts to the oxygen port itself, and then the tubing goes into that, and so basically the oxygen just runs down. And it bubbles up through the sterile water, and it goes.
So it plugs right into the side of the ambulance then? Can you, does it have a control for how many liters per minute?
Well, it goes on to the like the regulator with the control,
Okay.
and then it just goes on like where the tubing would normally go on.
The point is, Brian, you'll probably never see it.
No, yeah, well, I mean,
I've seen it in the house a couple times, but not like.
the longest run we'd ever do is like 25 minutes. If we're out with
Yeah,
office or
yeah,
something.
no, go over to the bubbles.
I mean, even when we're transporting
Maybe-
2+ hours. Again, we never used it at once, because they were already on humidified oxygen from the facility I was going from, so.
No, I've never seen these. Like, we have a vent that we use. We have our vent and then our own pumps and stuff, but
You guys have a vent?
yeah, we have a vent.
Yeah, that would be so nice.
Yeah, we have a vent. We just got a new one, so everybody's super excited for the
You
new.
you guys have long transport times.
Yeah, and it's mostly for our like critical care IFTs.
Well, yeah, technically, regular paramedics on the ground can't use them in Montana. Technically.
Technically speaking, but we're Lake County. We do what we want.
Yeah. I gotta figure out. That's what we're seeing. And
Don't go down Fulton anymore.
You haven't in a while.
Had time,
All right, well, I'm glad you're here.
I mean, I can tell you which one's sharing, but I can't help you fix it. I mean, we struggled. Do you remember yesterday?
Turn off.
Oh, yeah, that's right, because you made me the host.
Oh, so dude.
Okay, there we go. Now you can.
if you don't have class.
That last week of March,
Last one.
it's the spring break, so the campus is closed.
There you go.
Now is it all working?
Yeah, you just might want to make it a little bigger. Yeah,
Yeah, there.
look at that.
All right.
Well, I can let them in now, so.
Those of you that are online, are you able to hear us and see us? You could just unmute yourself and just say hello.
Hello, good morning, guys. I can hear and see you just fine.
Great, thank you. Does anybody online, do you guys have any questions about anything? You guys able to get your quizzes done and your exam? I know a couple of you had extended a little bit further.
Yeah, I did one yesterday too.
Anybody else? You guys have any questions, comments, concerns?
We should be through what, week 5 quiz, or is that where we're at now?
We're in week 6.
Are we, should we have taken week six?
I did.
Schedule week 7. It's written down in my notebook.
Yeah, we are week 7 right now.
The newer stuff you guys added, where is that for later, the stuff that you added after the quizzes?
Yeah.
Okay,
Yeah, I'm just trying, I have added up to week 12.
okay.
So I just don't want to get behind, especially if I have to have surgery. So I'm gonna probably this weekend we'll get the rest of them put up for the rest of the course.
So how are you guys finding those quizzes? Is it helpful in looking at the material, trying to find it in the book? Even though it may not be word for word. I just also want to reemphasize, don't cut and paste anything from Platinum onto Google. They have some spiderware that will find it and they'll tell on you and it'll let me know. And if we get a lot of people doing that, then we get banned. I've got a student I'm trying to get resolved that did that in our paramedic class. So I don't want that to happen to you guys.
Just to clarify, Kyle, you're saying like, you don't even do a Google search using the same wording, is that what you're saying?
Yep.
You're not talking about posting anything, you're talking about,
No, yeah.
Don't
If you copy and paste that shit, it will lock up your computer.
Yeah.
Just don't even use them.
Copy anything from Platinum, put it into a Google search. So
What's
if you want to know, hey, what is the dosage for diabetic ketoacidosis, what insulin, or whatever the question is, just ask questions on Google about that, but never copy directly and paste. That's what gets us in trouble.
I copy and paste it into a Word document and lock me up, so.
Yeah.
really?
Yeah,
So don't try to copy and paste it into anything. It's just a very high-tech proprietary system that's in place to protect their content. And it's also for your advantage because then you know other people aren't selling the test, getting all the answers, not having to study, passing the test, and then you're going, how's that possible? So they're really, really strict. They just don't have very much wiggle room. Okay. All right, so we'll get started. Neurological disorders. Okay, so neurological disorders are on the rise. There's all kinds of things that can affect the neurological system. And today we're going to talk about stroke, seizures, headaches, neurological diseases, infectious or neurological disorders, affect the brain, affect people, affect non-traumatic back pain can also affect the system. Anything that you're dealing with the central neuroprocessor, our brain and the spinal cord, is going to affect your sympathetic, parasympathetic nervous system. And so these are things that we have to keep in mind when we're coming across patients, is we've got to determine, is this a neurological disorder? Okay, quick anatomy and physiology. I'm not going to spend too much time into this, just because a lot of that content's in the book. I'd rather get into the systems and that's. Okay, just as a quick reminder, the sympathetic and parasympathetic nervous system, all part of your autonomic nervous system. They work in tandem with each other. One is always going to be dominant or more dominant than the other, just depending on the condition of the patient. Being able to recognize somebody that's in sympathetic dominance versus parasympathetic dominance. What would you see if somebody is in sympathetic dominance? What does that indicate?
They're stressed out.
Okay, so stress on the body. So somebody's in fight or flight, dry mouth. What are some others? Tachycardic. Okay, respiratory rate's going to be up.
Sweating.
Okay, GI system will shut down or slow down significantly because the body says, I need to fight for my life. So if we come on to patients that are in sympathetic dominance that are showing symptoms of shock, we need to figure out what is causing that shock. Is it stress induced? Is it a disease process? Is it a loss of blood? Something is not in sync and the body is feeling a threat. Okay. Whereas parasympathetic dominance, what are we going to see?
Relax.
Yeah.
Lower blood pressure.
Right.
Pulse rate.
Okay. Calling 911. Can that be a sympathetic response? Yeah. Stress. You have people showing up, coming in a truck or an ambulance. That's always going to bring up that blood pressure and heart rate. Just our presence because there's something potentially wrong or there is something. So it's recognizing whether your patient is in parasympathetic dominance or sympathetic dominance. Okay, major functions, central nervous system, brain, spinal cord, peripheral nervous system. So this is a feedback loop that lets us know our environment, the cold, the heat, our somatic is voluntary. So if I decide I want to walk across the room, I make a choice and I walk over there. Autonomic, which is involuntary. I don't have to think about my heart rate. I don't have to think about breathing necessarily. It's going to automatically do those functions. Okay. This is how the central nervous system or the nervous system works. The central nervous system, peripheral nervous system. They have the feedback loops that then let the body know where they are in space and what's going on, and people can sense a lot of these things, and some of it is very subconscious, we're not even aware of it. Okay, functions of the sympathetic and parasympathetic. Alpha-1 receptors, this is helpful when we're looking at some of the drugs that you guys may be administering, is a lot of these drugs will mimic like alpha-1 receptors, beta-1 receptor drug. So it is specifically targeting those receptors and causing response to the body. So for example, beta-2 receptor, bronchodilators, simple one, giving somebody albuterol. So now we're taking over and giving the body a stimulant that says, hey, we want the bronchioles to dilate so that we can get more air into the lungs, so that that patient can do gas exchange. So it is important to understand alpha, beta, beta two, and how they all work together, and understanding those drugs that are specifically addressing cancers. Okay, synapse cleft, how the neurons respond to that stimulus, cause muscles to contract, relax. There's certain types of drugs that can affect those receptors or paralyze them. So understanding how acetylcholine works or acetylcholine, these are all neurotransmitters, dopamine. They affect the body in different ways as far as movement, motion. You can increase, for example, dopamine, we can increase the contractility of the heart. So we're going to stimulate the heart muscle to squeeze harder so that we can increase blood pressure as an example. Norepinephrine, how that can affect the adrenal gland. So all of these neurotransmitters, we have some drugs that can actually stimulate and increase that function. Okay, understanding the major parts of the brain, the cerebellum, encephalon, midbrain, pons, medulla oblongata. You guys saw that movie Waterboy? Something's wrong with that boy's medulla oblongata. Okay, the cerebellum. These are important. And the reason we need to understand just the basic functions, obviously, neurology is much more complex. We just want to keep it simple. What is the patient's symptoms? What are they displaying? That can also lead us to different parts of the brain that can also give us indications as to what part of the brain is being affected. Okay, so the frontal lobe, think of this as where you're thinking, reasoning, judgment, making decisions, doing your algebra. Okay, the temporal lobe is about memory and visual memory. You've got right and left. Okay, so temporal lobes right there on the side. Parietal, this is to do with balance and sensory. Understanding language. Occipital, this is where it takes up a good portion of the back part of our brain, where we talk about how the body is able to process through the optic nerve what the visual environment that we're in. The cerebellum has to do with muscle tone, coordination. So if you look at some of these diseases that can affect these specific areas of the body, and it makes more sense why that portion of the body is being, or brain is being attacked or inhibited, that you're going to see decreasing muscle tone, for example. Medulla oblongata regulates the breathing and cardiovascular function. Information between the high brain center and the spinal cord controls the skeletal muscle movement. This is all important with letting us be able to breathe, and the pons, we get into that, that's part of that reptilian part of the brain. So it's the basics of where our body goes to when trying to function and survive. And when those areas get affected by drugs or alcohol or stimulants of some sort, or if there's any sort of bruising or bleeding, then we'll start to see these areas of that reptilian part of the brain, the basic functions, become affected. Then we have the thalamus, and you guys can read through these. This is just a great way to just simplify the different functions of the
And
brain.
that's why I put them in there.
Yeah.
Not necessarily, we need to talk about everything, but.
Yes. Okay, so presentation and complaints. So what are some of the things that you guys have seen with people that have had neurological changes?
A repetitive question.
Okay, so that's one symptom. Okay, so that could be to a head injury. What's another one that we can see?
Mood swings pretty rapidly.
Okay, so there could also be mental disorders that could cause people to be happy 1 minute, angry, upset, crying the next, back to happy. When we look at scene size up and we're doing AVPU or we're doing GCS, You see how that mental capacity is what we're really assessing first? How aware is my patient when I'm coming up onto the scene? Are they alert and oriented to me? So what do we do with ANO times 4? To person, place, time, event. Who's the president is a question. How many quarters make a dollar? We can ask these questions that people should be able to answer relatively quickly and be able to give us a good idea. When I ask somebody who they are, they should be able to tell me their name, where they're at, approximately what time. And it doesn't have to be precise, but is it in the morning? Is it the afternoon? Is it the evening? That's pretty general where everybody should know. Do you know where you're at right now? So we should be able to say, well, I'm in this classroom, or I'm at home, or I'm on the side of the road, I-90, wherever it is. They should be able to answer those questions. If that's something that they can't do fully, then we need to think a little bit more about what is impairing their ability to think and to be able to answer those simple basic questions. Okay, so let's see. So you may have behavioral changes, sensory impairment, headache, weakness, paralysis, tingling, just having a worst headache of their lives. These are questions that we can answer pretty quickly. Okay, assessment, treatment, airway, breathing, circulation, disability, and environment. We've gone over this numerous times, but it's really simple for us to be able to walk up to a patient and get just a general idea of, hey, how alert and oriented are they? Are they talking? Well, we know they have an airway. Are they breathing? What is the respiratory rate? What is the circulation? So we can get those baseline set of vitals. And then just figure out if there is anything that's inhibiting their level of consciousness. And sometimes it can be the environment. So what other things could affect somebody's environmental condition that could affect somebody's neurological capacity? Coordination. What's that?
Temperature change.
Yeah, temperature change. They're too cold, their fine motor skills are gonna decrease. If they're too hot, that can also affect their ability to reason and make decisions. Electrolytes, and we'll talk about some of those other things that can inhibit that. Okay, so being able to do that quick assessment gives us a baseline of where to start looking at. And here's a bunch of medications, and this is a simple, you guys can go through this, but you'll probably see some of these medications on a more regular basis with your patients. And I strongly encourage you to take that extra time when you're talking with your patients, ask them, what are you taking this medication for? They should have at least an idea of what it's for. They don't have to give you the whole breakdown, but I take this for a seizure. Now, there are some drugs that can be used for multiple purposes. And they're always trying to figure out new ways to be able to apply a particular drug that's already there, and how can it affect the patient, or how can it improve their condition. So having these basic medications, have an understanding of them is helpful when you're talking with your patients. Sample OPQRST, we've talked about that in depth. Basic vital signs. One of the simplest ones when we're doing that assessment is get a blood sugar. I've had numerous times where I've gone to, have you guys ever been to a nursing home, 2 o'clock in the morning for altered mental status? Like I'm at altered at 2 in the morning. Okay, but I ask them simply, did you check a blood sugar? And I get this blank stare. That's a simple test, right? And I can't tell you the number of times I've gone to a nursing home for altered patient with a blood sugar of 24. I'm like, well, you guys could have checked the sugar, right? Like, that doesn't take rocket science to figure that out. So we should also be thinking of it that way too. Simple things can sometimes, they're hypoxic. And there are other things that are much more complex too, okay? But let's make it simple first, and then we can start. Let's see, chat. Can you check to let people? Oh, yes, we will. Anybody else? I don't know how to automatically do that.
I don't either. I don't see anyone.
Yes.
Oh, there it is.
There it is. Okay.
I'm gonna figure out how to fix that now.
Okay. We're gonna try to Because in my other classes,
It just lets you in.
automatically, they just, maybe as a setting I did, where. Okay, so neurological exam, what should we be doing? So there could be things that we need to consider, okay? Intracranial pressure. Is there any way that we can measure that in the field? No. However, we can measure blood pressure. Okay, so if they have a really high blood pressure, that could be affecting it. Doing a rapid physical exam on critical patients to see if there is a head injury or see if there is something that's causing that patient to have those symptoms. Perform a focus exam with our non-critical patients, determining GCS. Looking at pupils is another way. That's a window to the soul, right? Looking in someone's eyes, being able to look at that. Assess motor sensory function, pulse PMS, okay? And then any stroke screening tools that you can use. There's a variety out there. I know you guys use, what do you guys use?
Just-
Fast, lambs?
I use
Yeah, we just changed to be fast. We're not using
Fast?
that anymore.
Okay, all right. And so just know what those are and how we can do it. We're gonna talk about those. That's always a quick way. We can do a quick assessment, check a blood sugar, check a SpO2, check blood pressure. A lot of these we can start to narrow down real quickly if it is one of those that's being affected. Okay, here's fast. This is what they talk about in the textbook. Facial droop, arms, are they weak, numb, speech, if it's slurred, I just slurred my speech, right? I'm not having a stroke right now. Time. Why is it important with time?
Strokes are very time sensitive. There's a certain drug you can only give within like 4 hours.
Right, so we have TPA,
Yeah.
okay? We want to be able to identify when was the last time this person was normal? Another one that I also ask, has this patient had strokes in the past? Is this their baseline that they're normally at? Because I've had patients that have residual strokes, that's the residual, that's where their baseline is. They are weak on that one side. Okay, but then I also ask, is this worse than their normal baseline for that patient? Okay. And obviously, if anybody scores, has those positive attributes to the different, to FAST plans, then we're gonna upgrade that patient to a stroke alert, and get the stroke team activated at the hospital so that they can get assessed by neurology and then make a determination of them going to CT. They want to see if there's a head bleed. They want to determine, is this a clot? Is this a bleed? And then they can give TPA. Let me go back here. There are differences in when TPA is given. Some, it's a 4-hour window, an 8-hour window, a 24-hour, or 40.
I was gonna say, they're pushing it in
They're
Montana.
pushing it to different levels. What's important for the hospital staff is when was it that you noticed this person was normal and when was the last time anybody knew it? And if we can kind of estimate that, then that's what they're really looking for. So be sure to try to get that information and be as accurate as possible, okay? And let them sort out. I just activate the stroke team and then I let them decide what they're gonna do, okay? So I would not, someone's had a stroke within 2 days, just let them know this is what they have. And if they want to make a full stroke alert or a partial, that's fine. Let them figure that out. But what I wouldn't do is, oh, well, it's been over 48 hours. We're not going to make this a stroke patient.
Well, we got in the protocols either a stroke 1 or a stroke 2.
Yeah. So make it a stroke 2 then. And then let them decide. They can always upgrade it, they can always downgrade it, but just don't dismiss it. Okay, if they have those symptoms, let them decide, the hospital. GCS, we've already gone over this numerous times, but this is important, especially with anything that is affecting that patient neurologically. We want to be able to get that baseline score for what we found, and do we have any changes during that transport? So if somebody had like a mini stroke, they may have more severe symptoms, and then as you're with that patient, they may resolve, right? Or a seizure, or Low blood sugar, okay? Get that baseline and then work from there to see if the interventions you're doing are improving, or if they're not improving. Okay. Understanding, making those decisions about whether somebody's in altered mental status, and just really try to eliminate the simple and easy stuff first. Recognize if it's a behavioral emergency. What would be some of the things we would consider with behavioral emergencies?
We just tell them because I have 3 a.m. or something.
Okay, right. You could also have,
What seemed like an altered mental status could be a baseline in some of your
mental health.
mental health patients, they may be their baseline, they're hallucinating.
So then trying to figure out, are they hallucinating? Do they take current psych meds? Are they currently taking those? If you can get a hold of their caseworker, that can sometimes be helpful in trying to narrow down what's going on. If they become violent and unpredictable, or their spidey senses are saying, something's not quite right here, don't be afraid to get law enforcement there in case they do become violent, and we have a way to be able to subdue them safely. Headaches, we have all had headaches, okay, but I always want to ask my patients a little bit more about what type of headaches they've had in the past. On a scale of 1 to 10, how bad is your pain? Are you having any vision loss or blurring of vision? Is this the most intense headache you've ever felt? Try to get some qualifiers there other than, well, I have a headache. Is this something we should be concerned with? Okay. Then looking at their vital signs. If we have a really bad headache, what would be some of the indications that this person's not having a normal headache?
Increased blood pressure.
Okay, increased blood pressure, what else?
Wouldn't you guys say like movement, like paralysis or?
Good, yeah, numbness, tingling, pupils can also be an indicator, really intense headaches, or they said, I felt a pop. Oh, that's not normal. That's not a normal symptom that you have with a headache. Vision disturbances, even bright lights, so those people that have migraines, now it could just be a migraine. There's more things we just need to find as far as the symptoms, and then we want to present those symptoms to the hospital, okay? And a lot of times they'll do a CT head or maybe a CT angio of the head to see if there's any problems that might be able to pop up. So those are some things that you might see. Slurred speech. Okay, so we need to determine, is that normal? Have they had any drugs or alcohol that could be impairing their speech? Or is there some other neurological deficit that's causing that speech to now become slurred? Extracranial versus intracranial, okay? Extracranial infections, hypoxia, toxins, environment, all of those things are, extracranial. Things that we can kind of be able to see. Intracranial, traumatic brain injury, stroke, epilepsy, those are all things inside the brain. Another one that I would also put in there is shunts. If any patient has a shunt, a lot of times those shunts can get clogged or taint, or they can fail, also causing more fluid or less fluid to be in the brain. So that would be the other one that I would add that we typically would see. Okay, AEIOU tips. This is a great one. As we're trying to sort out and figure out with the patient, what is causing their problem today? Just like decap BT, well, not decap BTLs, H's and T's. This is similar. So if we think of this person has altered mental status, what are some of the things we can quickly do to rule out AEIOU tips? So alcohol. What are some of the things we would see if they were under the influence of alcohol? Okay, all right. Slurred speech. Could we smell alcohol in the breath? Possibly. Coordination, right? What if we look around the environment? Do we see open cans of alcoholic beverages or used beverages everywhere? Okay, that might be vomiting. People saying, oh, they've been drinking. How much do people usually drink? You ask them.
2 beers.
Half of what they actually drink.
Yeah.
1 or 2 beers.
One beer, 2 beers, right? That's all they remember. That's how I look at it. So if they're just telling me 1 or 2 drinks, I can tell they're pretty sloshed. That's all that they remember taking. So, okay. So those are simple ways that we can see alcohol. Have you guys ever heard of taking vodka, and sticking a tube in your rectum and then consuming alcohol that way? That was a big thing they were
I was
doing
gonna
down
say
at
that-
university.
That was big in college.
Yeah, yeah.
The-
So then you would blow off the alcohol in your breath because it wasn't in your lungs, it was in your bloodstream through your GI tract. You could get drunk pretty quick. Okay, so that's a trick. So that would be a little bit more difficult to determine. Okay, seizures. How would we recognize seizures?
Patient has aura, reports aura, post-vicals.
Yep, yep. Witness, shaking, convulsing, okay?
And that's another one that history is gonna be really helpful with.
Sure.
Somebody has-
Some patients, when you ask them, or their family or friends, hey, what type of seizure meds do they have? Are there particular seizure meds that tend to work better for their seizures? Sometimes Valium's more helpful with controlling a seizure versus Versed. So sometimes it's just a type of seizure and the type of medication that can help get them out of that seizure. Okay, insulin, how do we check for insulin? Diabetic patients, simple Baker prick, right? And do that. Is it too high or too low? They have a history of diabetes. Overdose, what's a simple way that we can determine if somebody has drugs or not in their system?
Yeah, Narcan.
Narcan, if it's an opiate, right? But could we have other drugs that wouldn't be affected by Narcan? Yeah, well, we could look at what's in the environment.
Empty prescription bottles.
Yeah, empty prescription bottles, track marks, not always are they on the arms. I've also found them in the toes, and, they get real sneaky about it. Let's see, renal failure, uremia. How would we know if their kidneys are failing?
Presentation.
Okay, yeah, skin. They'll kind of have that uric acid smell to them because the body is trying to now weep that uric acid out of their system. You may also find that they've got the port, so never do the blood pressure right on the port. Trauma, obviously, we're gonna see some sort of trauma associated with that patient. Infectious sepsis, what would we know for our sepsis patients?
Fevers.
Okay, fevers.
Altered mental status.
Altered, right? Recent surgeries, maybe they've got an abscess or wound or.
History of UTIs. is kind of-
Yeah, so all of those things, we're suspicious of some sort of infection. Psychiatric condition, how can we determine that?
History.
Presentation and history, usually they act.
Okay, they're
It
acting
seems different than if they're,
Yeah.
altered mental status.
You can have people that have high highs and low lows. You can have people that are disoriented to their environment. They might change their voice tone. Another phenomenon that I see, and this is not to pick on religion, but religious deities, they will feel they are. I've met Muhammad, I've met Jesus, I've met Moses, and it's not a slam on religion, so that's what I'm not going at, but I see this phenomenon that they will take on this persona of they feel they're a religious deity of some sort. And that's not a normal meditation either. Let's see, what are depression, and we'll talk a little bit more about some of this too. Okay, stroke, we just talked about stroke and shock. Okay, let's see, mental status. Let me just kind of look at that. Syncope. Okay, so what are some of the things we might see with syncope?
Ringing in their ears, the tinnitus.
Okay, all right. What about locking your knees? People that are up on stage with the lights can sometimes be hot, or just, they might hear some news that can cause them to faint. We always see that in movies. They fall over. Okay, so it could be psychological, could also be environmental. Seeing stars, hearing ringing, those are all things that could cause syncopal. What's another one that we think about with syncopal episode?
Any cause or when someone's bagels out usually.
Okay, vasovagal,
You
okay.
see that pretty often.
Dehydration, also heart conditions can also do that. We can have a drop in heart rate.
Blood sugar.
Blood sugar, okay? So all of those things we can see that could cause somebody to syncopal episode. What's dangerous about syncopal episodes is, what if they're driving a vehicle? Or, they're walking and they don't catch themselves and then they hit their head on something or fall, off a train platform. I mean, there's all different things we don't like to have syncopal episodes. And if it's a first time syncopal episode, that can sometimes, if they become A&O times 4, we can kind of figure out, oh, okay, well, your knees were locked when you were standing at attention, or, you were up underneath some bright lights on stage. I always offer to take them to the hospital because I'm not sure if that's exactly what it is, but can people then sign a refusal and go home? Or go by POV? Yeah, it kind of depends, but I'm also gonna check the sugar. I'm gonna check their vitals. I'm gonna put them on the monitor. So I can make sure that it isn't something more serious, and now the patient's feeling that symptoms that are causing. And it could be just a simple syncopal episode, okay? So things to just keep in mind and think about. Okay, so we talked about cardiac arrhythmias, blood pressure changes, vasovagal response. They always could be potential life-threatening, but, could just be something simple and, not to be more significant. Okay, stroke. So there's two types of strokes: ischemic, which is a clot, versus a hemorrhagic, where there's a rupture in the blood vessel. Okay, so doing that stroke assessment initially within that first, 2 to 3 minutes on getting on scene and talking to your patient and finding out what's going on, we can then start to figure out, does this meet that stroke criteria? So what are some of the symptoms we're going to see? We've talked about it with BFAST or FAST or Cincinnati, whichever stroke system you're using to assess that patient. Note those findings and then activate, is this a stroke 1 or a stroke 2? The key thing is we don't want to spend a whole lot of time on scene. We want to get them to a hospital, a stroke center that can stabilize them. Okay. Here's all the risk factors. So as we're doing our assessment, trying to get a medical history, look at all these things that can be contributing factors. Okay. Listed there. Okay. Hemorrhagic. So this is where there's usually a weakening of the vessel or bulge, and then it ruptures. And depending on where that is in the brain and how big of a vessel that is affecting, I've seen some hemorrhagic strokes that go from being conscious to unconscious. They hit the floor, and there's nothing that's going to bring that person back because it's a significant rupture where they're bleeding out quite a bit, and they just die right then and there. Other smaller ones, it may take time for those symptoms to build up. It just depends on how big that rupture is and how large that vessel is, especially if it's down towards the brainstem where the circle of Willis is. And the reason that area is more susceptible is because it has sharper angles where the carotids come up and go around the skull, so not the skull, but the brainstem. That's where they tend to have some of those, and those can be more difficult to fix in. But you could have small ones that can leak for a little while and then build up pressure. The only way we're really going to know that is we're going to see some of those symptoms of a stroke, and it's CT angio or CT scan is what they're going to be able to see. So you may see a midline shift, or you may see blood infiltrating the dura mater, and that's what you're going to be able to see. But we don't have that capability. We just need to assess their symptoms. So, then we can have TIAs, which are basically small micro strokes that can happen, and it could be as simple as a small clot affecting a small part of the brain, and then it resolves on its own. So usually they have those stroke-like symptoms maybe for an hour or 2 hours, and they resolve. Or if they get in there and they're able to, see that clot, they can give the TPA and resolve and dissolve it. But a lot of the times the TIA will just happen and they'll go, okay, well, we just have to be aware of it. If a patient has a history of TIAs, they're more susceptible to having additional TIAs, until they may have a much larger, more significant event. Okay, so hemorrhagic, sudden, severe headache. They might say they felt a pop or a sensation. That's the differential. It's usually if it's a significant bleed, they decline pretty rapidly, in my experience. Okay, ischemia or a TIA, it's gradual, or they'll have symptoms that will then resolve on its own. Also with those hemorrhagic, you'll tend to see that the corticate posturing or the cellular posturing has that pressure on that bleed starts to increase. Okay, chain of survival, so pre-hospital screenings, maintaining your ABCs, get an IV established, because if we need to, we can give them some meds later. Be real cautious, especially if they have a really high blood pressure, not giving them too much fluids. We don't want to increase that pressure, cause a bigger problem. Always check blood sugar, notify the transporting, the facility you're going to, activate the stroke alert, that's appropriate. And think of fibrinolytic treatment, TPA, usually the sooner we can get them there, the better, because then there's a higher chances of having a positive outcome. Okay, seizures. Okay, what are some of the seizures that you guys have been on? What usually happens? Seizure kicks out. You guys arrive on scene. What do you usually find?
Sometimes still seizures.
Okay, yeah, or they may be in that postictal state. Okay.
Super confused.
Yeah, very confused. Are they AEMT ×4? Not usually. They're a little bit disoriented, but as that seizure wears off and more time comes around, they start to become a little more alert and realize, oh, I had a seizure, especially if they have a history of it. What are some of the causes of seizures? So epilepsy usually has to be diagnosed, okay? Somebody who has a history of epilepsy, they're usually on a variety of different medications to help control the seizures or minimize the seizure activity. Toxins, drugs can cause seizures. Metabolic disorders, traumatic brain injuries, strokes, tumors, fever. What about those fevers? Who usually gets affected by seizures with fevers?
Kids.
Little kids, okay? It's a first time seizure and it's a fever, body just kind of freaks out a little bit, and that child will have a seizure. It's usually pretty scary, obviously, for most parents, especially if they've never had any issues. Once that temperature gets to a certain threshold, the brain just kind of resets itself a bit. It's usually not life-threatening, but we need to figure out what's their temperature, have they been sick? I always recommend if it's a first-time seizure, let's go get checked out and make sure it's not something more serious. If it's a history of seizures and they are controlling that with medications, then it's really up to them to decide, hey, do I think I need to go in to get it reevaluated? If they're at all having a new seizure medication that's been introduced, or they're trying to determine the right dosage for that patient, then I really recommend, hey, you guys are still trying to figure this out. Why don't we just take you in and see your neurologist and make sure that the new treatment that you're undergoing is now being effective. And if it's not, let's get it resolved so you don't continue to have seizures. But I have done, high risk refusals. Someone's had a seizure, they understand why, and they don't want to go to the hospital. They're ANO ×4, and they've got someone there that's caring for them, then I'll do a high risk refusal, I'll call in the doctor and then say, hey, this person doesn't want to come in, but they're gonna follow up with their neurologist. And that's, it, based on individual cases, you guys make that call. All right, let's see. Have you guys ever dealt with some of will have dogs with them, seizure dogs? Okay, you guys ever heard of that or seen it?
yeah.
So the dog will smell or know that patient's about to have a seizure, and they're trained to let them know. They'll nudge them to get them to a safe place so they can sit down, have their seizure, to keep them from being, cooking and then hit their head on the stove. Or I had one young lady that was in her 20s. She was in the bathroom getting ready in the morning, had a seizure, hit her head right on her neck, fractured her cricoid, just like smashed it, swelling. Then she fell over and fell against the door, so her mom couldn't get in because she was laying up against it. Then came in, had to remove the door, kick it in, but by that time she had already died. So it's one of those things where you can have those seizures that can then, I've even had motorists that were driving and I go up to check on them. I'm like, wait a minute, this person's not looking right or having a seizure. And it's because they had a seizure while they were driving. So sometimes those seizures can happen at, times that are not. Okay, focal seizures, depending on what part of the brain it's affecting, generalized seizures. What is the reason we don't want to have people to have seizures other than they're not present? What's the risk of prolonged seizures?
Hypoxia.
Yeah. Okay, it's gonna cause more damage to the brain. That seizure activity could really disrupt, a lot of things as far as the body is concerned. That's why we want to try to get anti-seizure medications on board to break the seizure, and then hopefully determine what is actually causing that seizure to take place. So I worked at St. Joe's, which is the Barrels Neurological Institute down in Phoenix, and we had patients that they were trying different experimental treatment with because they were to the point that nobody else could really take care of them. That's why they came to that hospital. They were doing implants for stimulants to try to override that hyperactivity. They were trying different types of medications, different shunts, removing portions of the brain, a lot of different things just to try to help control that. Another one was using cannabis, and this is before a lot of these states were pushing cannabis, because it was illegal. But cannabis was shown to help with some of those seizure patients, just with the chemicals that are in cannabis to help soothe and reduce the seizures. So the key thing is we want to make sure we don't stick anything in their mouth that they're actively seizing. Make sure they're secured, they're not going to hurt themselves. Get ALS there, administer those anti-seizure drugs to help break that seizure. If the drugs that we have on the ambulance don't work, or on the fire truck, they're going to use more powerful drugs in the hospital to try to break that seizure. But most of the time, when people have a simple seizure, they may be out for a minute or 2 minutes. They're in that postictal state. I always want to get a blood sugar, get an IV started. The other thing with IVs, and I just want you guys to think about this, is try to stay away from the ACs if you know they have seizures, because when they seize, they're going to do this, and that makes it hard to be able to access and be able to give those meds. So if you can get them in the hands or the forearms, I prefer the forearms the best. Now I can still administer that anti-seizure medication should they go into a seizure when I'm transferring them to the hospital. Okay, let's see. So we talked about that. Get some high flow O2, vital signs. That. Okay. So tonic-clonic seizures, anything lasting greater than 5 minutes. This is the ones that are more concerning, because that brain is potentially being damaged the longer they have that seizure sustained. So it's real important to break that seizure. Okay. Headaches. We talked a little bit about this. Migraines, cluster headaches, tension headaches. We've all had some of those. What's the difference between someone who's having a migraine and someone who's just having a bad headache? What is the key difference that you'll see?
More sensitive to light. And
Like,
sound.
yeah. And I'll have patients that go, I'm having a migraine, but they're in an environment just like this, and they're not being affected by it. So to me, that's just a simple way of going, this is probably not a migraine. But the migraine patients, you usually walk in, the room is dark. They usually have a cloth or something over their head. And then that to me is more symptomatic of somebody who's having a migraine. I ask them if they take any medications. We're going to do our sample, OPQRST. It's where their blood pressure is really high. That's when I'm more concerned. They say they feel a pop or a sensation. They've never had a headache this bad before. This is the worst headache of their life, and they'll tell you that. That's where I go, okay, this may be more serious than just a tension, cluster headache that's causing the problems.
Have you any tricks that work with people with migraines? Anything that you
I just try to keep something cool on their head, keep their eyes, dim the lights in the back of the ride, try to minimize the noise and you know, things that are going to be more distracting, and just put them in a position of comfort and take them to the hospital. And it could be something more significant, but lots of, you know, people just have migraines, you know.
So usually if a migraine patient is calling you for a headache, it is the worst headache they've ever had. As someone who is a migraine sufferer, if I had to call an ambulance, it's because something else is going, like, there's a reason. Because these patients are very good at usually managing their pain, mostly. Like, we don't get a lot of calls for these. Another really big thing to ask with migraines is, did they get an aura? So most migraine patients will know they're gonna get one. Did they have the aura? Much like a seizure, right? It's the same thing. And they don't know why that is. So they're still trying to figure it out.
And then what have you done?
To take care of patients, or you, all the same things you did. The other thing is, a lot of times, myself included, I hate being cold, but for some reason being cold helps. And I'm sure it has something to do with the vasoconstriction. So they'll oftentimes ask like for the back of the ambulance to be cold, like, which is nice, easy in the winter. You just open the window and don't cover them up. So that was just the only thing.
Yeah, I was wondering about like oxygen or something. I know it might not be.
Yeah, you can give, I mean,
That's a
oxygen.
vasoconstrictor.
Yep. Yep.
I mean, you can, but it's just generally just keep it quiet, keep it dark.
Yeah.
Put a cold ice pack, you know, or cold cloth as you.
I think that the cold on the neck helps a lot too. So like a cold pack here and then a cold pack on the neck, so you're getting to the vasculature. Because what happens in a migraine is it's massive vaso dilation. So you want to try to clamp those blood vessels down. And a lot of the meds basically focus on that. So if someone takes a rescue med, and I've taken every single one of them, they'll say, it feels like I'm having a heart attack. They're potent. They jack your blood pressure up, they jack your pulse up.
Would you normally be hypotensive with a migraine headache then, or not necessarily?
Not necessarily. It depends on the patient.
The other things that can cause headaches. There's the one, I mean, you could have spinal issues too, can also cause that. I know or sinuses, also think about those. You've had a cold recently, changing from high pressure to low pressure can do that because the sinuses aren't equalizing to the pressure that's outside, and so that can cause stress too. Okay, subarachnoid hemorrhage, bleeding accrues at the base of the skull. May have stiffness, photophobia, so they don't want to see bright lights. A lot of times they'll have normal vital signs, LOC. No neck pain or stiffness may result in death. This is just something we just have to could be something that can slowly accrue. It's just that pooling of the blood from, some sort of a bleed. Okay, dementia. How many of you have come across patients with dementia? Okay, go into a nursing home, elderly patients generally are the ones that are gonna show a lot of this. So memory, not being able to, their A&O times 4 is gonna be different than the average person. So if I know they have dementia, then I'm gonna ask them, has anything changed from their mentation today? So it could be simply, normally they're talkative, but today they're not saying a word. Or they normally know their name, but now they don't. Okay, so we want to know what is their baseline for A&O times 4. That's going to be different from the general public or the general, people that don't have dementia. And then what is different today that is causing that concern? Alzheimer's patients, sometimes they can fluctuate between remembering things and not remembering things. Oftentimes they'll remember things in the past really well, but they won't remember day-to-day activities or what's going on. These patients can just wander off too. We've had, plenty of, they call it silver alerts now. So if somebody wanders away, that can be a big problem. It can also be a burden on the families too. With Alzheimer's, as it progresses, it can be not only psychologically affect the family or the care provider, can also be very draining on them. So if you see them also suffering and being exhausted because they're just trying to take care of this person and they're having a hard time being able to do that, try to see if you can help them get some help. Okay, so when you go to the hospital, hey, the family, you may notice things in the house, lots of dishes, things aren't being well upkept at the home. The patient may be wearing soiled clothes or doesn't look like they're being well taken care of. Not necessarily the intentionality of trying to be mean or cruel. I mean, obviously, if you see that, say something. But I've seen people that are caring for these individuals, they are also suffering and they also need to get some help. Okay. And sometimes it's just getting them connected with social services to get somebody maybe to come out and help them out a little bit, especially if it's an older patient taking care of a spouse or a loved one or a child, that can be really challenging. There's different types of dementias out there too. One of the more famous ones with the frontal temporal lobe dementia is Bruce Willis, which you guys probably heard about. And, he can remember some things, but then he just can't communicate, or sometimes he can. That's a progressive disease that just, eventually.
My uncle just died of this, and it's one of the longest. So from time of diagnosis to death can be a decade.
Yeah.
It is a very, very long process.
And it's a lot of upkeep. For
Yeah,
the
it's
family to try to keep them fed and.
Yeah, we kept him at home until he passed away, and it's a lot of work.
Not an easy thing. So if you see that fatigue, try to see if you can help them out by letting the nurse know or get them connected with. There's different organizations out there that can also help them. There's social services that are available. Okay, delirium, infection, metabolic disturbances, toxins, medications can have that influence on patients. So that's why we want to get good, history, sample, local QRST, hallucinations. They might be frightened easily, so you may need to talk softer. Maybe you don't need to go code 3. Turn off the strobe lights. Some of those things can cause them to be a little bit more amped up. They can go from being docile to being aggressive. So just make sure if you feel that somebody has dementia or delirium and you don't feel safe in the back of the ambulance by yourself, especially if you're a female, just have somebody else ride with you, because you'd rather have somebody out back there instead of you trying to fight off somebody that's having an episode. Okay, let's see. So we've talked a little bit about all of these different things. Oh, another one that we didn't really touch on is Bell's palsy.
Yeah, I didn't put it in there.
Yeah, there's
like,
so many.
There's so many, so
Yeah.
that list is like all of the ones that are in your book that I didn't think we necessarily needed to cover, because we don't see them a ton.
Is Bell's palsy. Do you guys know what Bell's palsy is?
Yeah.
The presence of facial droop
It's
from like
usually
a.
facial, so they're not necessarily gonna have the weakness in the arms and legs. There's a salt trick that you can do.
There's a
that-
salt trick and there's the forehead thing.
What's the forehead thing?
I gotta remember. Bell's palsy patients can furrow their brow.
Huh?
Or cannot, one or the other, and I'm gonna have to look it up, I can't remember.
So
And
it's-
stroke patients can or can't, I don't remember, I'm gonna look it up real quick.
So the Bell's palsy is caused from, what is it?
Facial nerve, which one?
Yeah, but it's also, it's a herpes
Oh, yeah, it can be herpes simplex
simplex
virus, yeah.
virus that can affect that facial nerve. If you put, now I'm not saying do this, but this is what I saw the ER doctor do, is he put salt, and if they could not taste the salt, then it was Bell's palsy. Because it's affecting that lingual nerve that affects the tongue, and so they won't taste the salt. To put it in there, they won't taste it. If it's a stroke, they're gonna taste the salt. Okay? But once again, that's not something, a differential you're gonna use in the field to then go, is this a stroke or not a stroke? I would just make it a stroke and let them determine that that in fact is a stroke. So I would hate for you to, oh, well, they took the salt and it wasn't, and then they're like, well, this was a stroke patient.
So Bell's palsy patients cannot furrow their brow because the nerve is paralyzed. With a stroke patient, it's not the nerves that are affected, it's vasculature. So,
I actually knew somebody not that long ago that had this and it was just came on from nowhere and
and then
and
something
then
just
resolved
goes away.
itself
Yeah.
within like 30 days or 45
Yeah,
days.
Yeah, and they often go to the doctor and they don't do anything for it. So,
Anyway, so that's just a little tidbit of Bell's palsy. Okay, all right, so we'll end. Do you guys want to take a quick 5-minute break? Did you guys on Zoom, did you guys have any questions?
I haven't seen any.
All right,
You wanna open up the next one for me?
Yeah.
Yeah, sure. And if we don't get the cabinet today, we have some turnover days coming up, so. Not the end of the world. I don't think this one's super long.
Well, didn't get a chance to look at those questions I sent you, but those were,
I didn't.
I got your email as well.
those are just a sample. There's a few other ones that were kind of confusing too, but those ones were definitely wrong.
Yeah.
Yes. I confirmed.
And the thing is I have no, like,
Well, yeah, you don't have control of the book or anything, but at least if you
yeah.
make it something you could alert the publisher to or let the class know.
Yeah.
One of them that was kind of a tricky one I didn't include in that list was that it was about title volume and the answer, I'm gonna find it for you. It was about title volume and it made you think it was to be 500 milliliters, but the answer was 350 because of the dead space. You know, it was, for the average person, what is the amount of air available for gas exchange in normal ventilations? Yes, it's 350 because of the dead space,
Yeah,
but another answer was 500.
Okay.
So that's confusing a little bit because I guess the amount available is 350 because of the dead space. So
right. And then you're compensating and, you know, and you can go back and forth with those volume levels. But what I look at is, if I look at capnography, my pulse oximetry, am I adequately ventilating that patient with what I'm giving them? And then, you know, that to me is just merely interesting numbers.
You think there'd be a benefit to carrying a flow meter like in the field or whatever? I mean, probably not, right?
Because all that you're gonna use that flow meter really is just to get total capacity of your lungs.
Right,
When you exhale, like when they're trying to do a lung study.
right.
So if you're, smoker, then you can know what capacity.
So people like asthma and COPD, some of those people may have one at home already or something.
Right, but they're, from a perspective of treating their disease, you want to see exact capacity is getting less and less.
Right. Right.
Or if you're doing, because you're gonna go, for like firefighters, we gotta have SCBA, we gotta be able to wear that. Well, there's a certain threshold that if your lung capacity isn't sufficient enough with that flow, then you can't be qualified to wear an SCBA.
Right.
Because you're gonna be at distress.
So you wouldn't be able to tell, I mean, you're just doing a snapshot of time
Yeah.
on a call, you
Yeah.
wouldn't, you'd need to
And
know the
it
history.
wouldn't really matter.
Okay, that makes sense. Which way were the bathrooms again?
If
Bathrooms,
you go right or left, eventually you'll end up.
come around the other side?
On the other side.
Okay.
Things. Hanging in
How's it
there.
going?
Yeah.
Yeah.
Good.
Heels in this hip was a poor choice.
Oh, no.
Don't love wearing heels.
Short. Well, tell your hip is better.
Yeah. My appointment's on Monday,
Yeah.
so.
Did you want to talk more about the EKG stuff that you were gonna record or touch on that later? Or,
Oh, yeah, I can mention, yeah, I'm gonna try to record maybe this afternoon. I teach at 3 online.
yeah, I mean, no hurry, I just,
I will most definitely do it on shift this weekend.
yeah.
Maybe tomorrow, but I brought it tomorrow. Difficult with her.
Yeah, figure out the.
No, I don't know what the hell we're gonna do. We have another tour tonight, so. I have a lot of friends who are just like, we'll just take her for now until we figure something out, so. On the computer.
I'll just, did you want to, you want to just use the one up there?
Oh, yeah, no, I just,
Yeah.
watching the
Yeah,
chat.
yeah, I'll just do that. I'm gonna go put these keys back. From.
Okay. I keep thinking your highlighter is a vape, and I'm like, wow, that's bold, just having your vape sitting there.
Oh, I don't vape. I get really annoyed when people do it around me. Like, I don't like this weird acidically sweet smell.
I would like to say that I don't, but,
It's like
I threw my last one away because I got berated by my friend. And I haven't bought one since, it's been like a week and a half. She was like, get rid of that shit. Okay, Katie.
I don't even think
Yeah,
we're allowed to buy
I was at
that.
the gas station yesterday and I was like, don't say anything, don't get one. Like,
Like, I don't know. Am I allowed to
What?
how old are you?
I'm 20.
Yeah, 18.
buy? Oh, I was gonna say, I don't even.
I thought or is it just tobacco that's, I think it's all nicotine up to 21.
Yeah, that's
Is
what I
it
think.
now?
Yeah.
I'm so old, I didn't know that.
They did that a year or two ago.
I thought, didn't they
Which
first
I'm sure-
just do flavored vapes? Or was it everything?
I think it's everything now.
I think everything went to 21,
No idea. You can't buy nicotine at 18 anymore.
which had to suck for like half of the firefighters.
Oh my god.
Wildland, like going from 18 getting addicted and then you can't get it till you're 21. I mean,
Yeah.
I mean, they all got it, so.
Oh, I was gonna say, yeah.
But
Those Zyn pouches are super, super common, or super popular now. They're just the straight nicotine. I did 3 milligram one time and I got so sick. Like, it's way too concentrated for me.
I could never.
Okay, you guys all good? I think we're waiting on one maybe, but that's okay. So we're gonna talk about endocrine disorders. This is actually a fairly short chapter. So the endocrine system is extremely fascinating and it is very complex, and endocrinologists are up there with immunologists as the smartest people on this freaking earth. You have hormones and chemical messengers that are secreted in one gland that act on something else, and then some glands make hormones, and then those hormones go into another gland that actually secretes those hormones, and it's all controlled by the nervous system, which is insane. The hormones do a lot of things. They regulate energy metabolism. They respond to stress. They have things to do with thirst and reproduction and all of your lower level functioning things that you don't have to think about, right? Your reptilian brain is what I was trying to think of. All sorts of signs and symptoms come along with these endocrine disorders, and it is the biggest system, one of the biggest systems, arguably the biggest system for maintaining homeostasis, things like kidneys and the buffering system and all that kind of stuff. We're going to do a quick anatomy and physiology review. We have lots and lots of glands in our body. These are collection of, they're ductless, so they don't, which is also really incredible. They secrete all these little messengers, and then they just go where they just know where to go, and then they're going to act somewhere completely different in the body, right? Without a duct system to get there, like think about your cardiovascular system. You have like this portal system, right? These things, they just don't care. They just go wherever, and they know where to go. Hormones regulate themselves. So you have things like releasing hormone, you have inhibiting hormones. And some of them only work in the presence of another hormone or a receptor or a certain protein, which is also very interesting. So this is just a picture of that receptor and the binding site. Regardless of what type of hormone, they mostly need a binding site on the cell. They can be on the outside of the cell, on the cell membrane, they can be on the inside of the cell, and they all do different things. I like to think about this as a lock and key mechanism. The key has to fit into that lock. And that is how the hormones know, the body knows where those hormones need to act. This we're just going to quickly touch on. So these negative feedback regulation loops in the paramedic program are really important, and we go very, very deep into these. Just know that the vast majority of hormones work in this negative feedback loop. You have some sort of releasing hormone that works on some gland, and then it works on an organ, and then in that target cell, and then it goes back and does the same thing. So that's kind of all we're going to talk about with the negative feedback loops. They can get extremely complicated very quickly. You have anything else to say about that? No? Okay. So here's just some, I'm not going to talk about all of these, right? I put these in here for your reference because it's a nice way of organizing the information for you so you don't have to do it yourself in the book. Some of the biggest hormones that we deal with come from the thyroid. The posterior pituitary gland, antidiuretic hormone, and oxytocin. So ADH is really important in what? Antidiuretic hormone. Diabetic patients is one of them. And then oxytocin does what? Uterine contraction, yep. It also stimulates milk production in postpartum women. What else? Growth hormone, don't really deal a lot with that. Thyroid stimulating hormone. No need to memorize these ones necessarily. The ones that are important are the glucagon, insulin, and those somatostatin cells or hormones, because we deal with those all the time, right? In our diabetic patients. These are, the pancreas is an endocrine gland. They are stimulated by the levels of glucose and amino acids in the bloodstream. What is a drug that you guys will be able to give that will directly affect this?
The wrong one.
Which one?
Glucagon?
Glucagon, yeah. So glucagon is, it's a great drug if you can't get a line on a patient and they have extremely low blood sugar. What glucagon does is it promotes gluconeogenesis, and it sucks whatever is left in the liver, okay? those last stores of glucose or glycogen that are stored in the liver get pulled out by glucagon. There is a couple patient populations that you don't want to use these on, one of those being alcoholics. Yeah, because of all the toxins that are in there, and they don't have any reserves left. There is nothing in there, and you can do a lot more harm than good. And we talked about, it's on the summary slide from neurology, Wernicke's encephalopathy is a condition that you can get in alcoholics. They really, what they need is B12 and sugar, because they cannot make it on their own because their livers are so trashed. So if you have an alcoholic patient, be very cautious about using glucagon. I will tell you right now that endocrinologists and ER docs hate this drug because it is very hard on patients' bodies. And once you have to think about when you give glucagon and you've sucked everything out of their liver, right? Everything that's left, there is nothing left for them, right? So if you don't correct the problem and get their blood sugar up with traditional means, getting them food, getting them, D10, D25, we don't use D50 anymore, really. These patients are going to tank. And if you give a patient glucagon, it's one of those patients that you really need to strongly encourage to go to the hospital and not refuse care. We had a frequent flyer in Kalispell that had, he tried to, he really was trying hard to manage his diabetes, but he just, for whatever reason, his body was not responding well. And I probably gave glucagon twice a week to this guy. And we had to transport him every time because it is so hard on the body.
Yeah, it doesn't mention anything in the protocols about that. It's funny that they.
Yeah, I know it doesn't. But yeah, docs don't love this drug.
Right.
And then obviously epi and norepi are two of the biggest ones that we're going to deal with on a daily basis in our jobs. So there are three main functions of the hypothalamus. It's one of the largest most important endocrine glands in the system. It controls the pituitary gland. So the pituitary can't do anything without the hypothalamus. It does that by secretion of releasing hormones. So like the gonadotropin hormones are all releasing hormones or inhibiting hormones. The two big ones that you do need to know from the hypothalamus is diuretic hormone and oxytocin. Those are really the only two I care about. And it also has to do with nervous stimulation of the adrenal glands. Again, that's the feedback stuff that we don't really care about. The one we do care about is the pancreas. It secretes insulin to control blood glucose levels. Glucose is the preferred energy source for many cells. It is required for normal cell metabolism. It is required for all of the pathways, gluconeogenesis, glucogenolysis, which is breaking down that glucose, and then gluconeogenesis, which is creating glucose from the glycogen stores in the liver.
Yeah, we switched
These pathways, if you are interested, you can look them up. They're extremely complicated. In my master's program, I had to memorize all of them, and they were evil. There's so much that goes into these pathways that we don't really care about. And quite frankly, as a medic, I don't really care about anymore either. So the hormonal effects of insulin and glucagon, we kind of went over this already. Insulin is the dominant hormone when blood glucose is high. So trying to get that glucose out of the system. It has major effects on most target tissues. All cells in the body can uptake glucose. The liver, it's increased production of glycogen, protein, and fat when insulin is high. And then the liver and fat, when insulin is high, increased production of fat. Glucagon, like we've talked about, is the dominant hormone when blood glucose is low. So it is a naturally occurring substance in your body. When you are giving glucagon, the drug is a synthetic hormone that just overloads the system, basically. It increases that glucogenolysis, meaning pulling all of the rest of the glycogen reserves from the liver. And then it is that increase in glucogenesis, which is what turns the fat in your body into glucose, which is further why it's really hard on the body when you're already in a state of not homeostatic state, and you put all of this in here, and now the system is like, oh my gosh, I have to not only pull it out of the liver, and if it gets to that point where all of those stores are out of the liver, now it's going to use fat. This is the idea behind the keto diet. Does anyone know? I will not get on my keto soapbox right now. I think it is the most harmful thing that you can do to your body if you do not have a certain condition. Do you know what this diet was created for?
I was gonna say ketoacidosis.
Do you know?
No.
Seizures.
Oh.
Yeah, there was some very interesting research back in the 50s and 60s, and these patients, these seizure patients, were put on the keto diet, and they don't know why, but it significantly decreased seizure activity in these patients. So a lot of patients, seizure patients, are on this diet. It is very harmful to your body. And soapbox for like 30 seconds. My biggest pet peeve is people will be like, oh, I'm keto, right? But they don't track their macronutrients. They have no idea how much they're really eating, right? And they just eat a bunch of like bacon and sausage and whatever. And it's way more harmful than good. It does work. It actually does work well for diabetic patients as well. Some doctors will prescribe it for diabetic patients. But again, have to be really careful with it. So. The thyroid and adrenal glands. Thyroid is very interesting. There's a couple different types of hormones that are secreted by the thyroid, T3 and T4, and each of them do something different, and you can't have one without the other. And then you have thyroid stimulating hormone, which is the one that actually stimulates the thyroid to make T3 and T4. And if you don't have thyroid stimulating hormone, we're going to talk about the pathophysiologies that come along with either overproduction or underproduction of these specific thyroid hormones. And then the adrenal glands, very important. Does anyone know where the adrenal glands live? They sit right on top of your kidneys, and they are the ones that secrete epi and norepi in response to the sympathetic nervous system. And we talked a little bit about what causes that in the last one. Okay, so common presentations. I really liked this picture because it has everything on it in one. Like everything you need to know about endocrinology as an AEMT is on this little picture. It's great. You can get altered mental status, weakness, fatigue, abdominal pain, palpitations. You're gonna get all sorts of signs and symptoms. Diabetes. We obviously go on diabetic patients a lot. DKA patients. What's the highest blood sugar that you guys have seen? High. So yeah, a lot of monitors in the hospital.
Down to like 550.
Okay.
But it was high before we gave him a liter of fluid.
Yeah, and that's the only thing that, because we don't give insulin in the field. Not even, I think flight medics have it in Montana now. We used to not have it. But yeah, so high. And I think every monitor is different. Most monitors, high is 700 or higher, I think. Ours is 700 or higher, I don't know. Yeah, those patients are super sick. Addison's disease, we're going to actually talk about this in a couple of slides. Very interesting. I have a friend who has diabetes and Addison's disease. So when he is in a diabetic and an Addisonian crisis, it's not good. Yeah, so we'll talk about all those. I have slides on them. So these are some common medications. If you're asking a patient about their medications, that you might see indicating that they have some sort of endocrine system dysfunction. Levothyroxine is very common. Lots and lots and lots of people are on levo. There's some interesting research out there nowadays saying that maybe that's not the best course of treatment for these patients, and things are changing. Those next two I haven't actually seen in the field. I've heard of them. Haven't seen patients on them. Patients are on all sorts of different steroids for all sorts of different things. We have steroids that we can use in the field, insulin, obviously. And then there's a bunch of new medications coming out for type 2 diabetes. And it's really, really hard to keep up with them. Metformin is the biggest one, is the biggest indicator, right? Oh man, I forgot what it was. They're now prescribing metformin for something else that is not type 2 diabetes related. That was an off black label use. I'll have to look it up.
Is metformin also, they also use that for pre-diabetes, like too, when someone.
Yeah, yes, that's the big one that they use for type 2 pre-diabetes to try to stop that from.
So does that mean you probably wouldn't be on it once you had progressed to type 2 diabetes or would?
Yeah, you would probably be on, it's more of the, like a stronger medication. And then a lot of type 2 diabetics will eventually end up being insulin dependent these days, fortunately.
I think you might be thinking of metformin being used for PCOS.
Yes, thank you. Yes, PCOS, polycystic ovarian syndrome. Yeah. Thank you. That's awesome. Yeah. So it's prescribed for women in the trying to get that blood sugar down, which has something to do with those cysts that form an overproduction of all of the hormones. Yes. Okay, so we're going to talk about some specific disorders right now. So type 1 diabetes, this is the genetic one. Usually it's onset in, you're born with it or it's early childhood. I have had actually 2 friends who were diagnosed in their 30s as type 1 diabetics, where that gene just gets turned off. They don't know why. It's very interesting. There's a lot of genetic testing going on right now about it. But the gene for insulin control just gets turned off and the pancreas is like, I think I'm just too tired to work, and it stops. It's the destruction of those beta cells in the pancreas, which causes little to no or no insulin production. That type 2 diabetes we're all very familiar with. It is the middle-aged diabetes, obese patients, usually controlled by oral medications, but as they progress, they usually end up being insulin dependent. This is just a compare and contrast. So the cause of type 1 of diabetes is autoimmune, and type 2 diabetes is lifestyle, insulin resistance, not taking care of yourself. Risk factors, both have a genetic risk factor component. Obesity is a big one. So my father-in-law has type 2 diabetes, and he's actually pretty fit for his age. Like, he still hikes a bunch, and he's still he's a logger, so he's still hucking a chainsaw around. My dad is 400 pounds and has been for the last 35, 40 years, and he, other than his joints being replaced, is healthy as a horse. No type 2 diabetes, no heart disease, so there's a huge genetic factor in that. Hypoglycemia can happen for a lot of reasons. They take their insulin and they forget to eat. That happens fairly frequently. Or there's a lot of people, most patients now are on a pump, and there can be pump failure. What do you do when you have an insulin pump failure? If you come across a patient that has failure of an insulin pump, just take it off and get them to the hospital. Just take it out so that it can't put more in. Hyperglycemic emergencies, things like DKA. Usually we see these in poorly controlled diabetics or diabetics, kiddos that have not been diagnosed yet. And then complications, all sorts of diabetes causes all sorts of problems, especially in those that are not controlled well. And then management of both of these things, diabetic diets, careful monitoring of that blood glucose level, taking insulin, and then really important for those type 2 diabetics to exercise, eat well, change their lifestyle, monitor, take their meds. How many of those patients actually do that you are aware? Yeah, not many. Usually they don't care. So diabetic emergencies, we get called to these all the time. Normal blood glucose levels. Some textbooks will say 80 to 120. Some say 70 to 110. Around that is normal. anything less than 60 is dangerously low, and anything above 140 is considered high. This is like blood pressure. It's very patient dependent. My blood sugar runs very low. I run in the 40s and 50s. Yeah, and I do okay. I admittedly only eat like one time a day at night, and I do fine. It's not a big deal. Some patients, if you get to 50, they're unconscious, right? It really just depends on how your body reacts. Same thing with hyperglycemia, right? 140 actually doesn't seem that high anymore. Most of our patients are around the 140s, 150s, 160s, and they're not having any problems. I think it's when you get up above those 200s now that you really start to see.
Yeah, I mean, we
symptoms.
regularly run into people, right, that after they've eaten a meal are 140, 150.
Yeah, and it's no big deal.
I see people that are operating on their normal mentation at 325.
Right, exactly.
It's like,
It really just depends on the patient. Yeah. So diabetic ketoacidosis is when we really get, we kind of get the big symptoms, right? There is way too much glucose and not enough insulin to wash out the system. This is when the cells begin using those fatty acids to create ATP. It produces ketones and decreases the pH. So this is the keto diet, right? They're like, oh, I want to be in ketoacidosis. Like, actually, no, you don't. It's really not good for you. Your body is working way harder than it should if you have normal physiology. I could soapbox about this all day. It drives me absolutely insane. It's the body's the body attempts to compensate by blowing off CO2, and you get those Kussmaul's respirations, right? It just absolutely floors me that patients or people are walking around trying to put themselves into a pathophysiology that is going to harm them. I mean, I guess we were just talking about nicotine, so there's that. You know, we all do things that maybe we shouldn't, drink too much alcohol, too much nicotine, but you can get, these patients are going to be altered if their sugar is that high. They're going to be altered. They can get cardiac dysrhythmias. They are going to be lethargic. They're extremely dehydrated. These patients are very thirsty. In fact, that's one of the ways that diabetes in kiddos and young adults gets diagnosed. Is a lot of times kids will just be like, oh my God, you know, like they're just drinking all the time. I had like a couple weeks where I freaked out with my kid when she was like around 1. She was like just drinking water constantly, and the daycare was like, yeah, she's drinking a lot more water. And I'm like, no, like that was the first thing I thought of. I took her straight to her pediatrician. They did the test. Diabetic, it's fine. The joys of being a provider sometimes. And then treatment, monitor the ABCs, these are patients that still get large volumes of fluid, because you need to wash that stuff out, with the caveat that you're continuously checking the lung sounds before and after you give that fluid, which you should be doing on any patient, but especially on these patients. So HHSM is what it's called, hyperosmolar hyperglycemic state. So this is basically diabetic ketoacidosis and type 2 diabetes. They still have a little bit of insulin left. It's basically the same thing, but they're not producing the ketone bodies. You're not going to know the difference between diabetic ketoacidosis and HHSN, really, other than they're not going to have the Kussmaul's respirations and they're not going to have the free smelling breath. How many of you guys have been on the drunk patient that was actually in diabetic ketoacidosis? One of my first calls as an EMT, way back when in like 2006, I had this happen to me, and I transport this patient. I do this great radio report. I was pretty sure they were just drunk as crap. And the doc was like, did you check the blood sugar? And I was like, no, why would I check the blood sugar? And it was a frequent flyer, right? So I learned my lesson, right? I think I was still a probie. I wasn't even like, I was a third. And we checked the blood sugar and it was like 985 or something. And I was like, okay, I'll always check the blood sugar. So you have to sometimes learn that one the hard way.
So easy to do, but it's also so easy to forget.
It is, I know, it is. Like, I mean, the two things that I do, I mean, you know, my assessment, if you ever work with me in a bus, you'll see is the exact same every time, all the time. And two of the things that I never miss now are blood sugar on every patient and lung sounds. Because I can say in court, yep, I do it on every patient. Like, yes, I did it, and it's in my report. So, hypoglycemia, low blood sugar, usually sudden onset. You can get seizures with this. These patients are going to be altered or unconscious. We just talked about blood glucose. And then this also triggers the release of epinephrine. I don't know if you guys knew that. But when patients are severely hypoglycemic, their sympathetic nervous system will kick in to overdrive. Yeah. And you get those early signs and symptoms of the sympathetic nervous system drive. So signs and symptoms: that altered mental status, bizarre behavior, irritability, weakness, headache, weak rapid pulse. They're going to be pale, cool, diaphoretic. We've all seen a hypoglycemic patient. They don't look good. Follow your protocol. If they're awake and able to control their own airway, encourage them to eat or drink something. This is the only time that we do that with patients that we are treating, is these hypoglycemic patients. And then if they have a decreased level of consciousness, traditionally we were giving that D50, that 20. I don't know if you guys ever did that, but you know, you put the IV in and it's like pushing maple syrup through. It was ridiculous. Oh man. We don't necessarily do that anymore because it can cause a lot of damage to that vein. And a lot of times it'll erode that vein so much that it'll pop, and then you get that extravasation reaction, which is just not good. Yeah. Now we're using D10 or D5, and then glucagon is available as an option, but be cautious of using it. So I think we've talked about this before. These are actually usually turn into refusals, right? Diabetics that have a known diabetic condition. They messed up, they gave, you know, whatever. They're usually like, oh man, I'm so sorry, I won't do that again. And then they do it again 3 or 4 days later, and you call and you get it back, and then they sign a refusal. I wonder if that guy in South Kalispell's still alive. I would be surprised if he was pretty old when I was there.
Yeah, I don't think so. We're running out of frequent flyers.
You're running out of them. Oh, that's
Better or
good.
for worse, yeah.
Yeah, okay, so he's probably not there anymore. His house was like the last house. It was like on 8th Street or whatever, that really weird street that
Oh,
we
yeah,
still
yeah,
had.
in the corner.
On the corner, wait.
Yeah, he died.
He died, okay, yeah, he used to live, I don't know if you remember that board member Larry. He was
Yeah.
like a couple,
Yep.
the end of that street.
Yeah,
That
yeah.
very house, yeah.
Yeah.
And I always thought that was super weird that we still have that the city hasn't taken. That one
They
street,
crossed through
You
a
have to
large portion of somebody else's district.
Kalispell's district,
Yeah.
and we have 8th Street or whatever, I think it's 8th Street.
Yep.
Yep. So, yeah, so we gave glucagon to that guy all the time, and he did just fine.
I don't think we have any frequent flyers left
On 8th Street. no.
in general. I think
Yeah.
They're all gone now.
They're all dead.
Silverlinks lady just died too.
Well, and Kalispell took some of South Kalispell.
Oh, did they?
Yeah, we get annexed pretty hard.
Yeah, they
Oh,
had
that
some of
sucks.
the trailer parks and stuff.
That stinks. There was another little old lady that we had that was, what's the name of that island down there?
Leisure Island.
Leisure Island.
Yeah.
We had a little, she's probably passed away. She was she was really cool. She was a biology professor at like some big university, like Stanford or something. And her house was super cool, and she had all this like biology stuff all over. I'm sure she's passed away. She was in her 80s when we were taking care of her, and that was 10 years ago, so. But I used to watch Zillow frequently to see if her house went up for sale, because I really like that house. I never saw it go up for sale, so who knows? Okay, yeah, so refusals, talked about that. Thyroid disorders are very interesting. And it is kind of incredible what etiology you can get from these thyroid disorders. So you can get 2 types. You can get the thyroid disorder where they secrete way too much, hyperthyroidism, they have extremely high metabolisms, weight loss, heat intolerance, other problems. Question?
That's me.
Well, right. I always joke, I'm like, if I could just get a little bit of hyperthyroidism and maybe a little bit of a cocaine addiction to like be really skinny. That was always, my cousins and I are like, what are the other? So yeah, these patients are usually really, really skinny. They have extreme heat intolerance. And they're usually cold all the time. Hypothyroidism, these patients, have a lot of weight gain, especially in the central area. So these patients will have like balloon bellies and really tiny legs and really tiny arms. So it's central obesity. And then this picture is really interesting. So this is a goiter that actually grows on the thyroid. And do you know what what our food industry has done to actually combat this? really interesting. So we have things like, salt that has iodine added to it. That's why. It has something to do with the regulation of the thyroid hormone. And these, after they figured that out, started adding iodine to things, and this problem, was largely mitigated, right? So,
Have you seen, people there's people that are in like central parts of countries like Africa, for example, where they don't have access to iodine.
yep,
These huge.
Huge, yeah.
just Because their body is trying so desperately to get iodine that it
Yes.
is just.
yeah, it's crazy. I lived in India for a year and we saw a lot of it. I lived in very rural India in the villages and we saw a lot of that.
You could just get some seafood.
Right, seafood or like salt
Yeah, with iodine.
with iodine in it. That's why all of our salt, like, it's really hard to find, just regular table salt that doesn't have iodine in it. And also super interesting, so one of the this is not a drug that you guys will need to learn, but, a contraindication for the use of amiodarone is iodine, because it's in there. I actually had my first patient a couple of weeks ago, that was a trauma patient, but I was like, do you have any allergies? She's like, well, I didn't think I did, but the surgeon, when I had my C-section, said that I had a huge reaction to the iodine that they put on my belly. And I was like, oh, that's really good to know. You need to tell people that, because there is a drug that we give that, has that contraindication. And and I said, well, do you eat seafood? She's like, now that I think, I don't really eat seafood all that often. So I said, just be careful now. If you are a seafood eater, like, you have to be watching it. And telling, if you have to call 911 again or whatever, tell the provider that, because amio will kill you. Yeah. So she's like, oh, that's really interesting. I never even wouldn't have thought about it. So not that we really use iodine in the ambulance anymore, but Graves' disease. So this is a form of hyperthyroidism. It's an autoimmune disease. It is the increased production of that thyroid hormone, and the characteristic feature of this is those protruding eyes. I'm sure you guys have all seen the commercials for the thyroid eye disease drug. I don't remember the name of it that they're pushing now.
Bulging eyes.
Bulging eyes, yeah. And there's a couple actors or actresses who are, who very much have this.
Remember you were from, Frankenstein.
Frankenstein, yep.
Oh, yeah.
It was the.
Mel
it
Brooks.
was Mel Brooks.
Yeah, tall, super skinny, bulging eyes.
Right.
Yeah, yep. Hypothyroidism, they have an iodine deficiency, right? You can get the goiters. This happens from surgical removal of the thyroid gland. This iron deficiency picture got put on the wrong slide. I don't know how. I'll fix that later. You can get mild cases of this due to autoimmune disease, diet, all sorts of things can cause this. What we really care about is that myxedema coma. So this is severe hypothyroidism. They get respiratory depression, they get bradycardia, and you're not really going to know that this altered or unconscious patient has this unless they have medications in their medication list that indicate they're on some sort of thyroid med.
So question on that, so
Yeah.
hypothyroidism, it's so severe that dietary can't fix it. Right?
Yeah, like at that point, you're getting it removed, you're on medication. And so the surgery for that is still, and I don't understand why some surgeries they still can't do laparoscopically, but I had a friend that just had her thyroid removed, and it is a scar from ear to ear. They like cut your throat open and then they peel your face back. Like this part of your face.
Like an autopsy.
Pretty much, yeah. And then they get in there and take it out. And I don't understand why like that can't be done laparoscopically. The other one that's really interesting are tummy tucks aren't laparoscopic anymore either, or yet. It's like it's a huge incision. Like my friend was like, we should go get tummy tucks. And I was like, no, like why? First of all, why would I want to do that? Second of all, have you seen the scar? Like I think the scar is worse than having a little bit of like mommy tummy, right?
Oh, that's the rotting that can happen, like,
Yes.
I've seen it just rot off of people, oh my god.
Yeah, I've seen some just not, like apparently, medical tourism is a huge thing now, like people going to Turkey is one of the big, Turkey and Greece, I guess. Oh,
It's
Brazil.
been Mexico too for years.
Mexico, yep. I just don't know how I would, that, like.
Not the place you want to save money.
I had a girlfriend that went to Turkey and got like a 2-for-1. She got her boobs done and a tummy tuck at the same time. Yeah, she's like, it was only $13,000. And I was like, oh, okay. Like plus the cost of airfare or whatever. Like, I just don't know. I don't get it. This is just comparing and contrasting what I went over already. I like to put things in tables as a way to consolidate information. One of my biggest tips for people getting ready to take an exam, especially National Registry, is open your textbook. And if you need to just like consolidate a chapter, just read the tables and the graphics and the like flowcharts, and it gives you all of the information that you need, really. So if you're like cramming for an exam, which none of us would ever do for all good students, that is, a college professor of mine told me that one time, and it actually works pretty well. So yeah, and if you can consolidate things into tables, it helps. Adrenal disorders, there are 2 big ones that we're going to see: Addison's disease and Cushing syndrome. So Addison's disease, excuse me, is insufficient adrenal cortex hormones. Those are your epis and your norepis. So what kind of things do you think you would get with a patient who had Addison's disease and diabetes? How are these patients going to present to you? Sick or not sick? Very sick. These patients have altered mental status if they're still conscious. They have respiratory depression, they're hypotensive, they're bradycardic. These are very sick patients. Cushing syndrome, on the other hand, is usually long-term overexposure to steroids. So any sort of steroids that they may be taking for another disease that they have, right? You see this a lot in diabetics and patients who are on steroids for things like, sometimes patients will be put on steroids for like thyroid problems. So people who are on these for a long time, rheumatoid arthritis patients, typically get this over the span of their lifetime. You can get osteoporosis, hypertension. Diabetes is actually a big side effect of this because the pancreas gets destroyed. This moon face appearance is really common, and this is also where they're really obese around the trunk. And they have really thin extremities. In women, you see a lot of facial hair growth. These patients are very, very recognizable as Cushing syndrome patients. You can see them from a mile away. You're like, you have Cushing's because of the way that you look.
And that's then a lifelong.
Yeah, once you have this, you can't get rid of it, unfortunately. Again, just another table comparing and contrasting the two. That you can read at your leisure. And then these are just all of the things that we talked about. You can treat these patients with a few things that you have. So you have D10, you have D5, you now have glucagon as an AEMT. And the big thing with all these patients is anyone that has endocrine problems usually complains of being cold or too hot. Like they really do not regulate their body temperature very well. So just be mindful of that. So, okay. You want to do the next one?
Yeah.
Don't touch the computer. Oh, there we go. Okay. So we'll probably end with this unless you guys want to do the capnography today. We can start with capnography next week because we have a little bit shorter of a week next week. So it's up to you guys though. You want to stay, you can stay. If not. Yeah, I don't know if I did it right. But I have to go back. Why don't I?
Usually is that.
I know. Well, go over back to Zoom, or no, back to, oh, it's right there, right, but below. It just looks different. Over there below your home button. Up on your. Nope, over, below where where you would like refresh the page. Left side of your screen. Yeah, down there. No. It's below that. Go, just hit back. There, right there. You had your mouse on it. See the arrows? No, no. It's right there. Right there. Yes.
Over just a little bit.
Over. Now go down. Look at that. It just looks different.
Wait, what? I missed the entire thing.
It's probably because I opened the
Okay.
PDF instead of just doing it
Oh.
in Canvas.
Hematology. So this is our blood, platelets, plasma, a lot of different things that are in the blood products that help us sustain life. And we talked about hemorrhaging and how much blood we lose. We've already talked about that a little bit. Red. Just a basic anatomy and physiology overview. Plasma, approximately 55% of the volume of your blood, 92% of it is water. How often can you donate plasma? Yes, no?
Oh, it's a lot more than
No,
that.
you
It's
can
like
do
once a
that
week.
Twice a week.
Okay, I thought that's regular blood.
We work at a blood plasma donation center. How often can you donate blood? That's once a month.
Once a month.
Okay. And the thing is plasma is generated and regenerated in your body faster than red blood cells. Where's blood formed? The bones. Yep, that's why we make new blood all the time, replacing those damaged blood cells. So you have red blood cells, white blood cells, platelets, all of those have very specific function helping us. Need more chloride. Liver spleen eliminates aged or damaged blood cells. Kidney and liver secrete hormones to stimulate the red blood cell production. Plasma has different clotting factors, antibodies, and there's also other nutrients and electrolytes that are in there. Anyone can come up with a synthetic plasma that works. You will be the next Elon Musk.
Yep.
Okay, because no one has been able to crack that code to create synthetic plasma. There's been attempts to create blood. There's been a couple different types they've tried. But plasma, that is the goal. That's the true goal. Okay, there's different hormones that help stimulate that production. So if you have liver disease, or if you've got cancer in bone marrow, that is going to affect your red blood cell production. So it's all of these systems have to work in synchronicity to create blood. Okay. Red blood cells, and lifespan's about 120 days. This is what carries that oxygen and carbon dioxide out of the body. It's the transporter. Here's just a basic breakdown of when you spit blood. This is what you're going to get. You're going to get that plasma rising to the top. That's little flow. That's usually the white blood cells, and then you have hemocrite, which is the red cells. If you see an increase, and we are not doing blood draws in the field in the sense that we're also running those blood levels, your concentration. So understanding how to read those lab values can be helpful. but we just don't have the luxury of being able to do labs yet in the field. I know there are
I think it's
some
coming.
people,
Point of care testing is definitely coming.
they are trying to figure that. There was a big scam back in the early 2000s where it was a prick of blood and she went around and she got billions of dollars
I
and
remember
it
that.
turned out it was just a big scam. Because maybe one day we'll be able to do that, but we can't do that as of yet. Although I do know some agencies are also experimenting with being able to test for cardiac arrest. They can test the there's it's the troponins in the field. That's something that may be coming. There's iStats. This is where they can do a quick analysis, but those are really expensive. They do that a lot of
The
times.
machines aren't super expensive, it's the cartridges expensive.
Right, because they gotta make money somehow.
Yeah.
But we're not doing those because it's very expensive and they're gonna do that at the hospital.
Critical care is though,
Okay.
for sure,
Critical care.
flight is, yeah.
So this is just showing just approximately what the normal, hemoglobin levels are based on. Males are gonna have a little more, it's all based on body size. White blood cells, this is the law enforcement of our body's ability to fight off pathogens in the bloodstream. Essentially, they seek out, find those foreign bodies and attack them and try to break them down. And most of the time, we're unaware of it. Where we get into problems is when there's an attack on the white blood cells and the body is unable to fight off those infections. Or there's already an infection that's taken place that's systemic and white blood cell system is at already at its max trying to fight off whatever that infection is. So you'll see those white blood cells elevated. Some sort of infection. Platelets. So we are familiar with platelets. This is part of that clotting process, makes things sticky. So if there is a bleeding, this is what helps start to form that clot and that clotting mechanism. There's drugs that help to expedite the clotting factors to increase clotting if there is a bleeding. But this can also work as a disadvantage, especially if you've got that in the coronary arteries. Because coronary arteries are really small. So if we have a small tear or a piece of plaque comes off those platelets and that all of the chemicals that go involved into forming that blood clot will then form a clot inside the vessel that then causes these blood. Okay, homeostasis. The body's always trying to find that balance. Sorry, I was trying not to sneeze and then just went my way. Okay, so this is the different pathways that it goes to be able to maintain that homeostasis. Clotting cascade that goes into place. What's a way that we can disrupt that clotting cascade if somebody's having chest pain?
That's aspirin.
Aspirin, yeah, because it's going to make that blood more viscous. It's going to hopefully allow it to pass through that area of the vessel. That's a good one. Are there other things that people can take to help decrease? Yeah, so they could be on blood thinners, which also puts them at a higher risk if they fall or get injured or they're going to bruise very easily. So somebody that's on blood thinners, we really want to make sure that we know that already so that we can pass that information on. And could also elevate somebody to a level 1 trauma just based on mechanism if they fall, even a ground level fall. Okay, there's different types of blood types. Okay, do you guys know what your blood type is? Okay, that's helpful. The universal donor is O negative, so anybody that's got O negative, once the donor networks find out who you are and have your phone number, they will be calling you. Hey, look, I'm in to donate some blood, because that's the universal. You know, everybody accepts it. Do you guys know why we can't have different types of blood types? Why we can't mix it?
Each other a little.
Yeah. There's research now to take blood, any blood type, and it's actually has to do with the receptors. And they are looking at trying to eliminate, it basically comes down to glucose. And they can actually turn blood into being universal regardless of what blood type it is. So that is a lot of research in there to essentially reduce this different types of blood types so that we can have all blood can go through a process and become universally donated. Which, if you figure that out, that is another huge, huge benefit to humanity, but also it's gonna make a lot of money. Okay, RH negative. This is what they usually check for moms, especially if they are RH positive. So my dad was an RH baby. This was back in the 50s when he was born. So basically when my grandma gave birth to him, her blood mixed and it caused a severe reaction. So my dad had to get flown up to Portland in an airplane, which this was back in the 50s. There was a whole lot of, wasn't air medical transport in the same way that we have it today. And he had to be treated at a hospital in Portland or he would have died. So they do this test every time, if you're pregnant, they want to make sure you're not RH positive. Okay, this is just talking about the blood size. Okay. Management, okay? There are different syndromes out there too. You guys heard of sickle cell? Okay, so it's the crescent moon. So instead of that hemoglobin being a nice puffy donut shape, it actually looks like a sickle or a hat, or a moon shape. And that makes it harder for oxygen and CO2. Biggest problem is it gets stuck. It gets stuck in the small capillaries. And anybody that's having a sickle cell crisis is going to feel like pins and needles. They're going to be in a lot of pain. You also may notice priapism with sickle cell males. It's very uncomfortable. The treatment is trying to make them feel comfortable, but they just need a blood transfusion. And they're going to try to help flush out those sickle cells that just are building up and accumulating throughout the body. Warfarin, which is a drug for cardiac patients, that can cause an increase in bleeding. Leukemia infections, those can also, because of the fact that it's attacking the white blood cells, leukemia can make it harder, make for profuse bleeding. Excessive platelets, you can end up with a pulmonary embolism, or if for some reason that cascade or the clotting cascade system gets activated, you can see blood clots start to form, like small ones, all over the lung tissue. You can also get blood clots that can be in the leg, or somebody's recently had a surgery. Sometimes they'll put these screens in to help catch any potential clots, but sometimes those have failed. So a friend of mine, his mom ended up passing away because she had surgery. That screen that they had put in failed, and she ended up getting a massive PE and she died. Seeing size up. So obviously we know about checking precautions, primary assessment. We're going to do our ABCs, secondary sample, open curiosity, things to help us try to figure out a plan for what is potentially causing if there is a hematological disorder or injury. Okay. Let's see, abdominal pain, swelling, jaundice. What are some of the signs of jaundice that you guys would see?
Yellowing.
Yellowing, okay, sclera, that is indicating the liver's not working real well. Increased cardiac output, so you're gonna have a higher heart rate, respiratory rate, fatigue, weakness. Another challenge is like what I talked about with OB, pre or postpartum. We can see an increase of bleeding. Okay. Urea. TPI, these are all things that you may tend to see. I tend to see a lot of TPI with vomiting, choking, the red blotches on the face, and they usually just go away. Treatment. So what are we gonna do for somebody where they may have a blood disorder or some of the things? Fluids, okay? Oxygen, making them comfortable, warm. May need ALS if you need to. If they do need a transfusion, try and get them to a hospital that they can be able to get them transfused quickly. It's basically, if you just don't have enough blood, this is, that's what's gonna cause most of your problems. Eliminate that problem, patient's most likely gonna get better soon. Okay, hematological conditions, blood transfusion reactions. Have any of you guys been at the hospital when they've done blood transfusions? Okay, so what are some of the things that we look for if there's a reaction? Okay, they might feel discomfort, pain. The biggest one is a spike in temperature. And that is if somebody's getting transfused. So have any of you guys seen the process of them going to get blood for a patient? Okay, so they do a blood draw, they confirm that this patient is O negative, for example, or not O negative, but let's just say O positive. I keep saying O, B positive or B positive, or AB positive. They go, they double check that that blood is also A positive, AB positive. The patient's AB positive, and then they put a bracelet on, okay? And then they check the numbers, and they double check the numbers, because they really want to make sure this person is actually getting AB positive and that they are in fact AB positive, because they don't want to be giving AB negative, because then they're going to have an adverse reaction. So once you hook up the blood tubing, you start infusing the blood into the patient, then you need to check their temperature, check their vitals, and then about 15 minutes later, you need to recheck, reassess, and if you start seeing these symptoms, like up here, this is letting us know there was a mix-up, okay? It happens very rarely, but it does happen. But you can't, if you were to give them that whole, pint of blood, it would probably cause severe death or injury to that patient. So if you notice that spike in temperature, that's the big one, immediately stop. Okay, the body's going to attack that foreign, that's considered a foreign body. It's going to attack it and hopefully, process it, get it out of the system. But if you were to give them that full vial of, or not vial, but full, pint of blood, you could have some pretty significant consequences. Anemia. So what causes anemia?
Low iron production.
Could be low iron, yeah, okay. Disorders that are affecting the red blood cell development or lots of blood loss, okay, can also cause that. So a decrease in production or an increase in destruction of red blood cells is what could cause somebody to become more, right? So they will feel fatigued, they will look pale, have an increase in heart rate, shortness of breath. Knowing that somebody has a known iron deficiency, so what are some patients that might have a low iron?
Women.
Women, okay. Then also pregnancy can also cause that. Okay, so those are things that we need to ask and try to figure out. And what is the solution to this? Blood. Okay, we can give them some oxygen, we can give them a little bit of fluids, but really what they need is more red blood cells. Okay, sickle cell disease, which is what I talked about a little bit. So this is essentially what they think is, because people lived in these climates where there was a higher incidence of malaria, that this was a genetic evolution possibly. And that's where these sickle cells were developed to give them a higher chance of survivability. But the problem is that if there's lots of sickle cell and it starts to accumulate in the body, that's where it causes more problems. Okay. Leukemia. Okay, so what's the cause of leukemia? Yeah, so the white blood cells, they get wiped out, so it makes it really hard for them to fight off infections. They can end up, developing anemia, bleeding, infections. They're more susceptible because they don't have those white blood cells out there trying to maintain the peace. They bruise easily, bone pain, enlarged spleen, swollen lymph nodes, repeat of infections, and fatigue. And this is, they're gonna be diagnosed by the doctor. Okay. Lymphoma, cancer, so this can also affect the lymphatic sites. You either have Hodgkin's or non-Hodgkin's lymphoma. Survivability is pretty high, especially if you're gonna recognize it sooner. Multiple melanoma, cancer cells in the bone marrow, so that can be, so they're gonna need to have some sort of radiation or chemotherapy treatment, or maybe even removing the cancer. But why is this important for us to understand? Do we see these patients in the field? Yeah. So they may be undergoing surgery or completed surgery, not that they would even surgery to get there, but they've had surgery, they have one of these conditions, they may be receiving that radiation therapy, and they're not going to be feeling great. Okay, it's really hard on the body. So my experience has been they have just recently completed a treatment, been sent home, and now they're just feeling they can't keep any food down. They're becoming dehydrated. They're vomiting. They're weak, and they just look pale, and they just look sick. So we want to take them back to the hospital, because if they're not able to stay at home and be comfortable, they need to get reevaluated and see what else is going on. Okay. Be careful with these patients. Be really careful as far as we don't want to introduce any other pathogens to them. So make sure that your equipment is clean and sterile. Wear a mask. Be extra cautious with them so that you don't try to give them more. Clotting disorders. What are some different types of clotting disorders? So we can have clots that can deform. Okay, those aren't good because that can cut blood flow off to different parts of the body. You can get clots in the lungs, brain. You can get clots in the leg. Okay, you guys ever run on that patient that's diabetic, poor circulation? You can see the leg will get discolored, lots of pain. Okay, hemophilia. Okay, so this is a genetic disorder that happens. It was part of royalty that was kind of passed around from the males. So you have to have those two genetic components to be able to have somebody, so somebody can carry that. I'm trying to think that I have a slide. I forgot to. I know. Anyway, so somebody who has hemophilia, it's typically males. They just have the inability to clot. So they can get a minor injury or bruise, and it will just bleed and bleed and bleed and bleed. If they get a laceration or a small cut, it takes a long time so if they get a major cut or a major bruise, they'll have to go to the hospital and get treated there, because it just can't stop, or has a very hard time stopping. The DVTs, which I just talked about. So if somebody does have a DVT, it's usually in one of the blood vessels, and it's usually very painful and uncomfortable. The way they're going to determine that is they'll do an ultrasound, they'll see where that is, they'll try to break that clot down. But if those clots dislodge and start moving to other parts of the body and get stuck, then that can have some more serious, especially to the lungs and throat. Nice. Panic overreaction of clotting mechanism. Yeah, so people that are septic, blood transfusion, reaction, surgery, or severe trauma. Okay, let's see. So things we gotta think about with hematology is understand if they have a history of it. Are they taking any medications for it? What have they done to help themselves or treat themselves, or what care do they have? Do they see a specialist if they have a special type of blood disorder? Essentially, if you can stabilize them, keep them warm, give them some fluids, oxygen, and get them to a hospital where they can get some of that extra blood, that's probably gonna help solve most of these problems. Question? Chat, anybody have any questions? Did you want to,
We want to just start with it next week.
yeah, what do we do? I think we only have like 2.
I think it's like 2 next week, yeah.
Okay, so we'll do, capnography lecture
Beginning
next
next week, we'll start with it.
Yes, first one.
Yeah.
Just because this was a lot more. Anybody online, do you guys have any questions? Not, I'm gonna sign off.
I'm good, thanks.
Okay, see you guys next week.
Have a good weekend.